start.
Okay, the last class I have taught you everything about the extraocular muscles and the basics of its origin, insertion. Now it is time for us to learn something about binocular single vision. As the name indicates, binocular single vision can sometimes be asked as a short note, or in Viva OC question they'll ask you the definition of binocular single vision. So as the name, from the name, if you want to derive the meaning, binocular, if you close your left eye and then with the right eye, if you see me, you will see one image. If you do the other way, if you close the right eye and then see with the left eye, you will be seeing one more image. So mathematically, you should see two images. You have to see two teachers, but what you see when both the eyes are open is only one object. So even if two objects are projected, one each to each eye, what you see is a single image. So this ability of the eye to convert both the images that are seen by two eyes into a single image is referred to as binocular single vision. So both the ocular system and the brain try very effectively to convert these two images into single vision. So this is referred to as the ability of the eye to convert both the images into a single image through its ocular system, and the brain is referred to as binocular single vision. So we have to understand the subject under these following headings. First, you should know the definition of binocular vision, and you should talk about normal binocular vision, then the development of binocular vision, at what age it develops fully, and a few theories about binocular vision and the mechanism of binocular vision and the grades of binocular vision, and a few abnormalities that are associated with the binocular single vision. Then you should know a few tests. If you know the names of the tests, that's more than enough. You are not supposed to know the details of the tests that are necessary to assess the binocular single vision. So we will come to the definition. When normal individual fixes his visual attention on an object of regard, the image is formed on the fovea of both the eyes separately, but the individual perceives a single image. This state of fusing both the images into a single image is referred to as binocular single vision. This is the definition of binocular single vision. So this is to understand, for example, in one eye, the right eye, the patient is seeing a house, and in the left eye, the patient is seeing a tree. So the mechanism has got a fusing capacity wherein it fuses both the images together and looks as though a tree is there in front of the house. Actually, the depth perception also helps in keeping the tree at a particular distance, and this phenomena is better understood by this particular diagram. The binocular single vision is better understood by this particular diagram. What are the requisites for development of binocular vision? You have to have three components. You have to have a good motor mechanism and a good sensory mechanism and a proper mental process that can fuse both the images in the brain. So what are the motor mechanisms? Correct neuromuscular development so that the visual axes are directed to the object. The object of interest is known as the fixation point, and there should be overlap of these visual fields, and in the brain, in the sensory mechanism, you have to have approximately equal image clarity and size in both the eyes. There must be slight dissimilarities, but these dissimilarities are wiped off by the ocular system and the brain. Corresponding retinal areas are present in the retina, which will represent in the brain, and they fuse together to form these two images into a single image. So you have a good motor mechanism in the form of proper extraocular muscles which are properly supplied. Then the sensory mechanism wherein the corresponding points are there in the retina. And next you have a mental process wherein the ability of the visual cortex comes into play and it promotes binocular single vision. The basic laws of binocular vision forms the very foundation on which our current understanding of strabismus and its symptoms and sensory consequences is based. That is the reason why you are supposed to know a few words about binocular single vision. Knowledge on binocular single vision forms the basis for orthoptic treatments, which I'll tell you later. When you come to the treatment of strabismus, you have a treatment by name orthoptic treatment, and BSV forms the very basic for these orthoptic treatments and many physiological processes that are present in the eye. Coming to the development of binocular vision, as you know very well, in 2 to 3 weeks, the child is able to turn head to fixate an object. 4 to 5 weeks, sustained monocular fixation of large near objects is developed. At the age of 3 months, binocular fusion occurs. 3 to 6 months, there is stereopsis. Stereopsis is nothing but depth perception. And at the age of 1 year, depth perception is the ability to assess the distance between the two objects when they are slightly separated from one another. So that is known as stereopsis, also known as depth perception. At the age of 1 year, fusional movements are firmly established. At the age of 2 to 3 years, adult level of visual acuity is reached, and binocular vision also reached at that particular age. The theories of binocular single vision, theory of correspondence and disparity, which is most widely accepted theory. There are corresponding points in the retina and in the cortex which are capable of fusing the images. Okay. Next, you have a neurophysiological basis for fusion, and rest 4 theories are older theories. Alternation theory of binocular vision. It's enough if you know the names of these theories and don't go into the details. It's not required as an undergraduate to remember the various details of these particular theories. Projection theory of binocular vision, motor theory, and theory of isomorphism. Simultaneous theory of correspondence and disparity, I've described it. Simultaneous stimulation of corresponding points where the object transmits single vision impression with no depth quality. Simultaneous stimulation by two objects points that differ in character results in binocular rivalry. As I told you, you need not go to the details of it. If you just know the theories, that's more than enough. Diplopia occurs when disparate elements are stimulated by one object. Binocular single vision with stereopsis results when the horizontal disparity remains within the limits of Panem's area. Panem's area is a technical detail about the binocular single vision, wherein if it falls into the Panem's area, then there will be binocular single vision. Neurophysiology of development. There is no need to remember, there is no need to go through the details of this. Then you will come to the mechanism of binocular vision. You have to have a good visual axis. Visual axis should always pass through the fovea, and the retinal correspondence should be there. For example, point 1 in right eye should correspond with the point 1 in the left eye, and both the points are represented in the cortex at the same place, and that is the prerequisite for binocular single vision. Egocentric localization should be there, and horopter and Panem's fusion area again are the technical details which are part and parcel of the binocular single vision, and the details of which you need not know, but you should know there is something called horopter and Panem's fusional area. This is a diagrammatic representation of the visual axis. I think in the optics you have been told what is visual axis, what is optical axis, and I don't want to go into the details of all these things. So you have oculocentric, monocular, and egocentric binocular visual directions. So the third point, that is both fovea have the same space value, that is 0, principal VD, that is important. This is about the horopter, the details of which you are not supposed to know too much. corresponds to the Panem's fusional area. Okay, now you should know about this you cannot escape. Sometimes an examiner may ask you what is physiological diplopia. The diplopia elicited by an object point of the Panem's fusional area. When the object is in the Panem's fusional area, there will be single vision, binocular single vision. If it crosses the Panem's fusional area, goes away from the Panem's fusional area, there will be physiological diplopia. Crossed heteronymous diplopia, a temporal disparity is seen, and uncrossed diplopia, nasal disparity. Uncrossed diplopia is also seen in as a physiological diplopia. If you bring your finger much closer, then you can see two fingers. That is nothing but physiological diplopia. And you should know, sometimes you will be asked what are the grades of binocular vision. There are three grades of binocular vision. The first one is simultaneous perception. The object of interest is perceived simultaneously by both the right eye and the left eye. The second grade is fusion. Both these images are fused together by the ocular system. And stereopsis is nothing but depth perception. Stereopsis is nothing but depth perception, wherein when there is a small distance disparity between one object to the other object, the eye is capable of assessing this depth or the distance between these two objects which are one behind the other. The ability of this particular capacity of the ocular system to assess the depth is referred to as stereopsis. For simplicity's sake, you can also use a terminology as a depth perception for stereopsis. But when you are asked about the grades of binocular vision, whether you like it or not, you are supposed to use the same terminologies. That is simultaneous, the grades of binocular vision are simultaneous perception, fusion, and stereopsis. See here, one eye is seeing the cage, the other eye is seeing the dog. So the eye has got capacity. These are the images that can be shown to each eye by an equipment by name Synaptophore. I'll be showing the picture of that particular equipment in the next few slides. So one object, that is cage, is projected to the left eye and dog is projected to the right eye. And as a fusional mechanism, as I told you, binocular single vision is developed and patient will be able to see a dog inside the cage. Coming to the previous thing is simultaneous perception. Now we have come to the second grade of binocular vision, ability of the eyes to produce a composite picture from two similar pictures, each of which is incomplete in a small detail. For example, when you see with the right eye, if you are looking at a person, his left ear, left ear is seen by your right eye, but it is not seen by the left eye. But this deficit is overcome when both the eyes are open, and both the eyes will be having the ability to produce a composite picture from two similar pictures. It is not superimposition of dissimilar pictures, but whatever small details are missing are compensated both by the ocular system and the cortex of the visual cortex. This is again an example wherein dissimilar images are projected to each eye separately, but as a fusional mechanism, you can see the lower picture is seen by the ocular system. So coming to the stereopsis, the third grade of binocular vision, visual appreciation of three dimensions is referred to as stereopsis. ability to obtain impression of depth by superimposition of two images of same object seen from two slightly different angle. The retinal disparity, fixation disparity is the basis of 3D perception. Stereopsis occurs when retinal disparity is not large enough for simple fusion but small enough to cause diplopia. What are the advantages of binocular single vision of one eye are made less obvious by the normal image in the other eye? For example, even if the patient is having a very bad vision in the left eye around 6/9, in the right eye if the patient is having 6/6, when the patient sees with both the eyes open, the optical defects in one eye are made less obvious by the normal image in the other eye. That's a normal image in the right eye. Defective vision in one part of the visual field is masked because the same image falls on the functioning area of the other retina. These are the advantages. Field of vision is definitely much larger when both the eyes are open, and hence binocular single vision gives you wider field of vision in the atmosphere. It allows the individual to converge the line of sight and obtain a reading as to the absolute distance of objects, that is depth perception, and there is presence of stereopsis. Perception of distance of objects from each other or from the observer is referred to as perception of depth. Several clues contribute. Binocular clue and then monocular clues also contribute by perception of depth. These are a few examples for how we normally perceive depth perception. So these are the advantages of BSV. You have a stereopsis, binocular summation, large field of view, and a spare eye. So whenever there is what are the abnormalities now in binocular single vision? Whenever there is no binocular single vision, either due to the failure of the motor mechanism or due to the failure of sensory mechanism or due to the failure of mental process, you will have confusion, diplopia, which will cause suppression and eccentric fixation, abnormal retinal correspondence, and that can also give rise to Next, ಇನ್ನೊಂದು ಹಾಕಲ್ಲ, ಇಲ್ಲೇ ಇರ್ತೀರಾ ಅಲ್ವಾ? ಇನ್ನೊಂದು ಪವರ್ ಪಾಯಿಂಟ್ ಇದೆ. Sorry for the interruption. So it will give rise to confusion and diplopia, and then suppression, eccentric fixation, and abnormal retinal correspondence, and that can also lead to amblyopia. You should know the meaning of amblyopia. Amblyopia and amaurosis are very frequently asked YOC questions. Amblyopia partial blindness, while amaurosis means total blindness. Amblyopia is partial blindness. When the eye is not being used for about 5 years, for example, the right eye is perfectly normal with normal refractive status, and the left eye is having a refractive status which has not been corrected. If it's not corrected for about 5 years, it will go in for what is known as amblyopia, suppression amblyopia. The left eye has been suppressed for a few years, significantly for about 5 years. If it is suppressed without correction, if it is working, then it will go in for what is known as amblyopia, partial blindness. So many a times you will be asked what is the difference between amblyopia and what is the cause for amblyopia, what are the types of amblyopia, or various questions that can be asked in amblyopia. So you must know the meaning of amblyopia and various types of amblyopia. So the abnormalities of binocular single vision, you should know that the first one is confusion. When squinting occurs, the two foveas view two different objects that are physically separated in objective space and send two different images in a single cortical perceptual area. This leads to confusion, and confusion can lead to eye strain and headache. Diplopia, when squinting occurs, an object in space is perceived by the fovea of one eye and some other extrafoveal point of the other eye, which has a different projection or localization value in the space. Thus, an object would be localized twice in space, causing diplopia. This is a diagrammatic representation of both confusion and then diplopia. In diplopia, you can see that the two images are being formed. So to conclude, without the basic concept of BSV, it is almost impossible to understand strabismus and treat it. The advantage of BSV overweighs the disadvantage. You must know that the binocular single vision has got more advantages than the disadvantages. So what are the various clinical tests that we are supposed to do for binocular single vision? For retinal correspondence, you have a few tests, and for suppression, you have a few tests. I think the technical details of how to do the test need not be known by you. You just write down the names of the tests that are necessary to do binocular single vision examination, and as to how to find out whether the patient is having binocular single vision. First one is red filter test, then Worth FDT, Worth 4-dot test. FDT, the expansion of FDT is Worth's 4-dot test. Next you have Bagoloni's striate glass test, and the fourth one is after imaging test. These are the pictures that represent various types of tests. And as I told you, test for stereopsis, you have a qualitative test, you have qualitative tests and quantitative tests. You kindly write down the side headings of all these tests, and it is not required for you to know all the procedures in this particular binocular single vision. This is the picture of Worth's 4-dot test, Bagoloni's glass test, after image testing, stereopsis testing. Now, there is one more thing that I have to teach you today. That's about binocular, how to classify strabismus and what are the various types of strabismus. I will start in about a few seconds. Please give me a little time. ಇನ್ನೊಂದು ಪವರ್ ಪಾಯಿಂಟ್ ಇತ್ತಲ್ಲ. ಇಲ್ಲ ಇದು 3 and 4. So you will be asked what is the definition of strabismus and what are the various classification modes. How do you classify strabismus? And you will be asked about the concomitant squint and non-concomitant squint and how to treat it. So to start that, obviously we have to know the definition of strabismus. Normally, whenever we are looking at an object, the visual axis of the right eye and the visual axis of the left eye are parallel to each other in any gaze you think except in convergence. In rest of the gazes, in binocular movements, all the visual axes are parallel to each other. So we can say that normally visual axes of the two eyes are parallel to each other in the primary position of gaze, and this alignment is maintained in all positions of gaze. Misalignment of the visual axis of the two eyes is referred to as strabismus. That is the definition of strabismus. Then how do you classify strabismus? Broadly, strabismus can be classified as apparent squint or pseudostrabismus. Apparently, there is the eyes look squint, but when you see the visual axis of both the eyes, they are parallel to each other in all the gazes, of course, except in convergence. They are parallel to each other in all the gazes. That occurs in a few cases, which I am going to name in the next few slides. Next, you have latent squint, that is hidden squint. The first one is false squint. The second one, there is squint, but it is hidden, latent squint. The third, obviously, the third possibility will be a manifest squint. Manifest squint can be classified into concomitant squint and incomitant squint. So this is the broad classification of the squint. If you write a flow chart, it will be like this. Squint, apparent squint is also known as pseudosquint. Pseudosquint. Next you have heterophoria, which is referred to as latent squint. Then you have heterotropia, which is manifest squint. Manifest squint can be comitant or incomitant. Comitant squint and incomitant squint. Comitant squint is congenital, incomitant is acquired. So in incomitant you have paralytic squint, restrictive squint and spastic squint. So all these three effects will occur on the muscles. Muscle can be paralyzed, there can be restrictive movement of the muscle due to some fibrosis, or spastic, due to some disease there will be spasm in the muscle and hence there will be squint. So this is the broad classification of strabismus. So now we will come to the false squint or pseudostrabismus. In pseudostrabismus or apparent squint, the visual axes are in fact parallel to each other, but the eyes seem to have a squint. So when the eye turns medially, it is known as esotropia or convergent squint. When the eyes turn outwards, it is known as exotropia or divergent squint. So coming to the pseudo-esotropia, when do we see pseudo, that is false, esotropia, that is convergent squint. Pseudo-esotropia, which is also known as apparent convergent squint, may be associated with a prominent epicanthal fold, which covers the normally visible nasal aspect of the globe. The nasal aspect of the globe has got a specific measurement medial to the cornea and lateral to the cornea. So this particular phenomena wherein prominent epicanthal fold is there, in such cases the nasal aspect on the cornea, wherein you see the globe, is covered extensively and there will be negative angle kappa. In such cases you have what is known as pseudo-esotropia. When do you have pseudo-exotropia? That is false squint. which looks like a divergent squint, which is also known as apparent divergent squint, may be associated with hypertelorism. Hypertelorism is a condition of wide separation of the two eyes, and there will be positive angle kappa in this particular condition. Heterophoria is nothing but hidden squint. Whenever patient is opening both the eyes and is active, the visual axis of the eyes are parallel to each other, but once you remove the stimulus, the weaker eye goes in for squint or phoria. So heterophoria, also known as latent strabismus, is a condition in which the tendency of the eyes to deviate is kept latent by fusion. Fusion is a mechanism by which the brain tries to fuse both the images. So as long as both the eyes are open, the ocular system and the cortex both try to fix the gaze on the object of interest, and hence there will not be squint. But if you separate the eye by obstructing it, then behind the obstruction it will try to squint. That is referred to as latent squint. So as long as the stimulus is present, there is fusion and then there is no squint. As long as the stimulus is removed for the weaker eye tries to squint. So this is known as latent squint. Therefore, when the influence of fusion is removed, the visual axis of one eye deviates away. Orthophoria is a condition of perfect alignment of the two eyes, which is maintained even after the removal of the influence of fusion. So you remove the influence of fusion, even in such cases, there will be even if you bring an obstruction in front of one of the eyes, there will be the visual axis of eyes will be parallel to each other, and this condition is referred to as orthophoria. However, orthophoria is a theoretical idealism. In practice, whenever we are seeing any person's eyes, there will be what is known as physiological heterophoria. When you don't have an interesting object in front of you, it is likely that the eyes will deviate. This is known as physiological heterophoria. It's a form of relaxation for the ocular system. Coming to the heterophorias, again, if you know the side headings, that's more than enough. There are various types of heterophoria. Esophoria, it's a tendency to converge, as I told you earlier. It may be due to convergence excess type or divergence weakness type or a non-specific type. So convergence excess type, esophoria greater for near than for distance. Convergence weakness type, esophoria greater for distance than for near. Opposite of convergence excess type. The non-specific type does not belong to any one of these two groups. So also you have exophoria. It is a tendency to diverge. It may be due to convergence weakness type. There is weakness in convergence and hence the eye try to diverge, especially for distance. So greater for near, especially for near, it is greater for near than for distance. Divergence excess type, exophoria greater on distant fixation than for the near fixation, and the non-specific type doesn't belong to any of the above two. Hyperphoria, it is a tendency to deviate upwards, while hypophoria is a tendency to deviate downwards. However, in practice, there is no terminology called hypophoria. We normally express everything in terms of hyperphoria. This you have to remember. It is customary to use the term right or left hyperphoria depending on the eye which remains deviated compared to the other, deviated upwards compared to the other. Cyclophoria, it is a tendency to rotate around the anteroposterior axis. When the 12 o'clock meridian of the cornea rotates nasally, it is called encyclophoria, and when it rotates temporally, it is called excyclophoria. The etiology for heterophoria. What are the etiologies for heterophoria? The anatomical factors are there. Anatomical factors responsible for development of heterophoria include orbital asymmetry, if there is slight asymmetry in the orbit, Abnormal interpupillary distance, IPD is interpupillary distance. A wide IPD is associated with exophoria and a small IPD is associated with esophoria. Faulty insertion of extraocular muscle. You know the standard insertions of all the extraocular muscles around the limbus. Now, if there is any faulty insertion of one of the muscles, then it can give rise to heterophoria. A mild degree of extraocular muscle weakness also can give rise to heterophoria. Anomalous central distribution of the tonic innervation of the eyes. One eye is innervated, one muscle is innervated more and the other muscle is not innervated to the same extent. The number of fibers that are supplying are much lesser. In such cases also there can be heterophoria. Anatomical variation in the positions of the macula in relation to the optical axis of the eye. It has to coincide with the visual axis or the optical axis of the eye. If the macular position is not coinciding, in such cases also they can have heterophoria. What are the physiological factors? Age. Esophoria is more common in younger age groups as compared to the exophoria, which is more often seen in elderly. What is the role of accommodation in causing heterophoria? Increased accommodation is associated with esophoria as seen in hypermetropes and individuals doing excessive near work, and decreased accommodation with exophoria as seen in simple myopic people. Role of convergence. Excessive use of convergence may cause esophoria as occurs in bilateral congenital myopes, while decreased use of convergence is often associated with exophoria. Dissociation factors such as prolonged constant use of an eye or one eye may result in exophoria as occurs in individuals using uniocular microscope and watchmakers. We use only uniocular magnifying glass and they don't work with the other eye. So you must know what are the factors that are predisposing to decompensation. Inadequacy of fusional reserve, general debility and lowered vitality, psychosis, neurosis and mental stress, precision that is necessary in a job and an advancing age. These are the things that can cause phoria. What are the symptoms of, depending upon the symptoms, heterophoria can be divided into compensated and decompensated variety. Compensated heterophoria is associated with no subjective symptoms. Compensation of heterophoria depends upon the reserved neuromuscular power to overcome the muscular imbalance and the individual's desire for maintenance of binocular vision. So both the mental process and the ability of the neuromuscular system, if it is capable of compensating for heterophoria, then it is referred to as compensated heterophoria. So in such cases, normally the symptoms are much lesser, but in cases of decompensated heterophoria, patient will have symptoms of muscular fatigue. These result due to continuous use of reserve neuromuscular power. They include headache, eye ache, difficulty in changing the focus from near to distant objects, photophobia, which is not relieved by the dark glasses but relieved by closing of one eye. Symptoms of failure to maintain binocular vision are blurring or crowding of words while reading, intermittent diplopia. Diplopia comes and goes off due to temporary manifest deviation under conditions of fatigue, and intermittent squint without diplopia. Then symptoms of defective postural sensations can also be there. They cause problems in judging distances and positions, especially of the moving objects. This difficulty may be experienced by the cricketers, tennis players and pilots during landing. So proper examination of the presence or absence of heterophoria is very important in such cases, such occupations. So how do you examine a case of heterophoria? The first and the foremost thing that you have to do is proper refractive error, especially with cycloplegia, testing of vision and refractive error. If the vision is defective, then you should not only do dry refraction, you have to do refraction with cycloplegics What are the cycloplegics? Very commonly asked question in Viva Voce is, please name the mydriatics and cycloplegics that are used in the eye. There are 5 drugs: tropicamide, phenylephrine hydrochloride, cyclopentolate, fomatropine, and atropine. Out of these 5 medications, 5 drugs, first 2, tropicamide and phenylephrine hydrochloride, they cause only mydriasis. But the rest 3, that is cyclopentolate, fomatropine, and atropine, they not only cause mydriasis, they also cause cycloplegia. Cycloplegia is nothing but paralysis of the ciliary muscle, or it can also be called as paralysis of the accommodation. It is caused by the 3 medications, that is cyclopentolate, fomatropine, and then atropine. And you must also know, sometimes they'll ask you which are the drugs which cause partial cycloplegic effect and total cycloplegic effect. When such a question is asked, the answer will be partial cycloplegic effect is caused by cyclopentolate and fomatropine, while total cycloplegia is caused by atropine. So you must know what is retinoscopy. Retinoscopy is a method by which the refractive status of the eye is calculated by the method of neutralization, and the refraction, that is retinoscopy, should be done in such cases. Dry retinoscopy is without applying drops. Wet retinoscopy is by applying drops. When you apply cycloplegic, then it is known as cycloplegic refraction or cycloplegic retinoscopy. Then you have to do cover and uncover test. It tells about the presence and type of heterophoria. To perform it, one eye is covered with the occluder and the other eye is made to fix an object. In the presence of heterophoria, the eye under cover will deviate. So, as I told you, when both the eyes are open, there is very good fixation. But when you try to remove the stimulus by covering it with a cover, then behind the cover, the eye in question, which is affected, will deviate. This is cover and uncover test. After a few seconds, the cover is quickly removed and the movement of the eye, which was under the cover, is observed. Direction of the movement of the eyeball tells the type of heterophoria. For example, eye will move outward in the presence of esophoria, and the speed of movement tells whether recovery is slow or rapid. Then you have one more test by name, prism cover test. Prism cover test, if you know only the name of the test, that is more than enough. The details of which you may not know unless you are really interested in knowing. But whether you like it or not, you have to know everything about the 4th test, that is Maddox rod test, because it is very frequently asked short note question. And in the Viva Voce, they'll show you the Maddox rod and they'll ask you to identify and tell you the mechanism or the uses of Maddox rod. This comes invariably at one stage or the other in your examination as a question. So whether you like it or not, you have to know the full details of Maddox rod test. So what is Maddox rod test? First, I will explain the principle used in Maddox rod test. Patient is asked to fix on a point light in the center of Maddox tangent scale at a distance of 6 meters. A Maddox rod, which consists of many glass rods or red color set, they are set together in a metallic disc. So cross cylinders are set together. They are parallel to each other. These cross cylinders are parallel to each other. They are red in color and they are all set together in a metallic disc. This Maddox rod is placed in front of the eye with the axis of the rod parallel to the axis of deviation. What is the principle? So far we have learnt about binocular single vision. The stimulus for binocular single vision is fusion. So if you remove the fusion, then you will know which eye is deviating and how the latent squint is becoming identifiable, or heterophoria is becoming identifiable. Hope you understood. The stimulus for fusion is similarity of the objects. The stimulus for fusion is removed in making the object dissimilar in case of Maddox rod. So the fusion is broken. That is the principle that is used in Maddox rod test. What is the procedure? The Maddox rod converts the point light image into a line because it has got cross cylinders. Thus, the patient will see a point light with one eye, and in the eye in front of which I have kept a Maddox rod, he will see a red line. So, due to dissimilar images of the two eyes, fusion is broken and heterophoria becomes manifest. How do you measure the phoria? The amount of distance of the red line away from the light seen by the other eye is the amount of degrees that is given in Maddox tangent scale. Okay, the number of Maddox tangent scale where the red line falls will be the amount of heterophoria in degrees. In the absence of Maddox tangent scale, if you don't have a Maddox tangent scale, then the amount of deviation or phoria is measured by using prisms. The dissociation between the point light, which is seen by one eye, and the red line seen by the other eye is measured by the superimposition of the two images by means of prisms. You have to go on putting the prisms with the apex towards the phoria till both the images fuse together, and the strength of that particular prism which was used to fuse both the images is referred to as the amount of phoria. So this is about the technical and details and the procedure of Maddox rod test. This is the Maddox tangent scale where the numbers are indicated, and the numbers only tell us the degree of deviation of the eye. This is the picture of the Maddox rod which you are required to write down in an examination, or if you are given this Maddox rod, next time when you see a trial lens set or trial lens frame and the trial lens set, you can identify this Maddox rod which has got red cross cylinders arranged parallel to each other. They are bound in a metallic disc. So in orthophoria, as you see, in one eye the light is seen which is yellow in color, in the other eye the red is seen, red line is seen. Both the things are coinciding in orthophoric people, but in esophoria there are different places, and the distance between the two is measured by the tangent scale, Maddox tangent scale, and the degree of deviation is calculated. So hypophoria, hyperphoria, and exophoria. These are the diagrammatic representations of various phorias. Phoria, as you know very well, is a hidden squint which is elicited by doing these tests, and then per se when you examine a patient it may be latent or hidden. So these are the tests to bring out the hidden squint which are causing unnecessary eye strain and headache. So you must be able to write down these, reproduce these pictures. A few words about Maddox wing test. Maddox wing is an instrument by which the amount of phoria for near. So far we have spoken, when I spoke to you about the Maddox rod test, I was talking to you about the distant vision. So whatever dissociation is seen in distant vision is assessed by the Maddox rod, while whatever dissociation is present in the near vision, anything within 30 centimeters is referred to as near vision in ophthalmology, if you don't know. So Maddox wing test. Maddox wing test is an instrument by which the amount of phoria for near at a distance of 33 centimeters can be measured. This is also based on the basic principles of dissociation of fusion by dissimilar objects. The instrument is designed in such a way that though it's two slits, right through it has got two slits, right eye sees a vertical white arrow and a horizontal red arrow, and the left eye sees a vertical and a horizontal, line of numbers. The patient is asked to tell the number on the horizontal line which the vertical white arrow is pointing at. This will give an amount of horizontal phoria, and the number on the vertical line at which the red arrow is pointing, this will measure the vertical phoria. The cyclophoria is measured by asking the patient to align the red arrow with the horizontal line of numbers. This is the picture of Maddox wing, the equipment which is used for Maddox wing test. So this is a diagrammatic representation as to how you are going to measure esophoria, exophoria, and then hyperphoria, and encyclo and phorias. So next class I will probably teach you the measurement of convergence and accommodation. Even you are not supposed to know all the details of convergence and accommodation. Sometimes they may AC by A ratio can be asked as a short note. That is the reason as to why I have to tell you a few things about the AC by A ratio. That I will teach you in the next class. Okay, with that I will conclude the class, and we have learned about binocular single vision. We have learned about the types of squint, and we have gone into the details of only phorias. Rest of the things we have not touched again, we have not touched still. So phorias and what are the various tests that were used to identify the phoria, among which Maddox rod is extremely important, not only from the point of having a knowledge of testing phoria, but also from the point of the fact that it is very frequently asked in various examinations at various stages in the form of short note, in the form of YOOC. In practicals, they will show you Maddox rod, and then we'll ask you a few questions on Maddox rod. Okay, thank you. Santosh.
Orangdili, Argentine.